Hey everyone, welcome to The Explainer. Today we're diving deep into a really important topic, aortic stenosis. You know, it's actually become the most common reason for valve surgery in developed countries, so it's something we absolutely need to have a handle on.
All right, so first things first. What exactly is aortic stenosis, or AS? At its heart, pun intended, it's basically a plumbing problem. Think of the aortic valve as this critical gate that lets blood out of the heart's main pumping chamber. When that gate gets stiff and just can't open all the way, it's like a major traffic jam for blood flow. The heart has to work way harder to get that blood out to the rest of the body.
So here's how we're going to break it all down. We'll start with what it is, then jump into the signs and symptoms, including those classic murmurs. From there, we'll cover how to diagnose it, what severe really means, and wrap up with the latest treatment options. Pretty straightforward. Okay, let's get into our first section. To really get a grip on aortic stenosis, we have to start with the two main ways it develops. Understanding the cause is everything for recognizing who's at risk. This is super interesting because it shows you two totally different paths to the exact same problem. On one side, you've got a congenital issue. Someone is born with a bicuspid valve. It works just fine for decades, but then it starts to calcify. On the other side, you have the much more common wear and tear of aging. This is driven by the usual suspects: high blood pressure, cholesterol, smoking. And it's a slow burn, taking maybe 10 to 15 years to progress.
So, what's actually happening inside the chest when that critical valve starts to narrow? Well, the heart is put under a ton of pressure, and its response is a fascinating story of adaptation. And then eventually, failure.
This slide really lays out the domino effect perfectly. First, the valve narrows. That creates what we call afterload. Basically, a huge amount of resistance the left ventricle has to pump against. So, what does the ventricle do? It gets stronger. The muscle wall thickens. That's the concentric hypertrophy, to handle the extra work. And for a while, this works. But eventually, that compensation just isn't enough. And that's when symptoms start to pop up. And this brings us to a huge clinical point: recognizing when the heart is starting to fail. You have to know this classic triad of symptoms, and the mnemonic SAD makes it easy to remember: syncope, angina, and dyspnea. Fainting, chest pain, shortness of breath, especially when someone is exerting themselves. These are major red flags. Once these show up, the outlook without treatment is, well, it's not good.
Okay, so when you put your stethoscope on the chest, what do you hear? This is the classic finding. It's that harsh, systolic ejection murmur. Some people describe it as a crescendo-decrescendo sound, and it famously radiates up to the neck into the carotids. But here's a great clinical pearl. In older patients, you might actually hear it loudest at the apex. That's called the Gallivardin phenomenon.
And it's not just the murmur. There are other clues on the physical exam. You might feel the carotid pulse, and it feels weak and delayed. We call that pulsus parvosa tardus. You might even feel the heart heaving against your hand or a thrill. And that second heart sound, the S2, can get really soft or even split in a weird, paradoxical way because that stiff valve is just so slow to close. All right, so you've got your suspicions based on the symptoms and the exam. How do we go from suspicion to a rock-solid diagnosis? This is where our diagnostic toolkit comes into play. So we've got a few tools we can use to build our case. Sure, an ECG can show us that left ventricular hypertrophy we talked about. A chest X-ray might show some calcium on the valve. These are helpful hints, for sure. But the undisputed champion, the gold standard test that gives us the definitive answer, is the echocardiogram. Yeah, the echo is where the magic happens. It's like having a window right into the heart. We can literally see the stiff, calcified valve. We can measure how thick the heart wall has become. And most importantly, with Doppler, we can measure how fast the blood is trying to squeeze through that tiny opening. That data lets us calculate everything we need to know. And when it comes to the echo, this is the number you need to remember: less than 1.0 square centimeters. To put that in perspective, a normal, healthy aortic valve is about 3 to 4 square centimeters. So when it gets squeezed down to less than 1, that's our definition of severe aortic stenosis, period. Okay, so we've hit that magic number, less than 1.0. We know it's severe. But wait, there's more. The story doesn't end there. We have to dig a little deeper into the hemodynamics, because not all severe AS is created equal, and this has huge implications for what we do next.
Right, so that valve area is just step one. We have to look at it alongside the pressure gradient, how hard the heart is pushing, and the flow, or cardiac output. It's the combination of these three things that lets us really pin down how bad the situation is and identify some really tricky, high-risk patient groups.
This table is fantastic because it lays out the different flavors of severe AS. You've got your classic high gradient type, pretty straightforward. Then you've got super severe. But the ones I really want you to pay attention to are those last two, the low gradient, low flow types. Now, the one with a weak heart, a low LVEF, that kind of makes sense. But the other one, this paradoxical low flow state, that's the tricky one. The heart's pumping function looks normal, but the flow is low. These patients are super high risk and can be easily missed if you're not looking for it.
Okay, let's bring it home. We've diagnosed it, we've graded it. Now what do we do about it? Let's talk about the modern solutions for opening that blocked gate.
Look, the data here is just crystal clear. Once a patient with severe AS starts having symptoms, that chest pain, shortness of breath, or fainting, the clock starts ticking, fast. We're talking a 50% mortality rate within 3 years if we don't do anything. This isn't a situation where we can just wait and see. Intervention is absolutely essential.
So what are our options? Broadly, there are two. You've got SAVR, the traditional open heart surgery to replace the valve. That's usually the go-to for younger patients. Then you have TAVR, which is this incredible, less invasive procedure where a new valve is put in through a catheter. This is generally for older patients. And for that group in the middle, between 65 and 80, well, that's where the decision gets a little more complex.
And that decision is never made by just one person. The guidelines are very clear on this. You need a heart valve team. This means you get the cardiologists, the surgeons, and the imaging specialists all in one room, looking at all the data together. They consider the patient's age, their overall health, their anatomy, everything, to figure out the absolute best path forward for that individual.
So, let's boil this all down to a practical takeaway. When should you pick up the phone and call a cardiologist? It's simple. Any patient with those classic exertional symptoms, chest pain, shortness of breath, feeling faint, that's an immediate referral. And even if they have no symptoms, if you get an echo back that shows even mild to moderate disease, it's time to get a specialist involved to map out a plan.
And that brings us to our final thought, a question that's really shaping the future of this field. TAVR, that less invasive procedure, is getting better and better, and it's being used in younger and lower risk patients all the time. So the big question is, how is that going to change when we decide to intervene? Are we going to start fixing these valves before symptoms even appear? That's the debate that's happening right now, and it's going to be fascinating to watch.